Welcome back, everybody, to this incredible session that we're about to embark on here. Thank you all. And if you could move into the middle, because we've still got lots of people coming in and we want to make sure everybody has a seat in the room. I have two quick announcements to make before I have the great privilege of introducing our plenary speaker this afternoon. First, at 12:45 to 1:15 today in this auditorium, we're going to have a special lunchtime presentation about quality improvement in the Netherlands. Wim Schellekens talked about it early this morning, and I would encourage you to come and learn more about the system that we're here visiting in the Netherlands. There's no food allowed in the auditorium, but you can pick up your lunch and make arrangements for that. And then second, I want to make an announcement about a special session that we've just added on for tomorrow. Tomorrow, a special lunchtime session from 12:15 to 12:45 here in this room. And it's in line with our dedication of this meeting to healthcare services that are in the middle of natural or political difficulties, and how do we create vibrancy and recover from some of these. So tomorrow, we've got a session on quality improvement in Afghanistan. Dr. Nadira Hayat Burhani, who's the Deputy Minister of Health, is with us. And I think it's going to be an amazing session to hear from a leader who's working in the midst of this conflict. Dr. Nazreen Yorakile is the Director of Malalai Hospital in Kabul, and Dr. Mirwai Rahizimi, the Chief of PADI at USAID Healthcare Improvement Project in Afghanistan, will all be with us tomorrow. So I encourage you to make a note of that on your calendar. As I mentioned at the start of the forum, we've dedicated these days to people in healthcare who are leading in times of challenge and difficulty. There's nobody more qualified, I think, to help guide us in this next conversation than our keynote speaker, Emily Friedman. Emily is an independent writer, a lecturer, a health policy expert and analyst based in Chicago in the United States, but really working worldwide in disaster relief and recovery. Emily has been a leader, a most provocative help in pushing us in healthcare to think differently about what we can and should do, what we must do. And I don't want to take one more minute of time away from my dear friend, Emily Friedman.
Good afternoon. Following on Fiona's dedication of this conference yesterday, I would like to say that I am honored to speak in solidarity with healthcare workers around the world, in Afghanistan, Australia, Chile, Haiti, Iraq, Ivory Coast, Japan, Libya, New Zealand, and unfortunately too many other places, who are seeking to heal those who are wounded by disaster, whether natural or man-made. I also wish to dedicate these remarks to the heroic workers at the Fukushima Daiichi nuclear power plant who are risking their lives to save others. I also would like to make it clear that the views expressed in this presentation are strictly my own and do not necessarily reflect the opinions of my many colleagues in Cambodia and elsewhere who have been of such invaluable help to me during the last 3.5 years of this work. And although part of this story is a tale of tragedy, nothing I say today changes the fact that Cambodia is a magical, beautiful country which offers incredible sights. The great temple of Angkor Wat, the great temple of the Bayon. I took this photo specifically for you all. This is a hospital where a woman is giving birth that was carved 1,000 years ago. And this is the haunting, exquisite temple of Ta Prohm. Most important, the Cambodian people, in my experience, are kind, patient, and forgiving. I fell in love with the place when I first set foot on it in 2006, and I am still in love with it. There are a good bit of details on many of my slides. Almost all of them will be available through the BMJ website quite soon, including some helpful websites where you can learn more about what I'll be talking about, and a list of some of my writings on the subject, and those are all available on my website, which is just my name, emilyfriedman.com. Well, the question is asked, I think, in every country. If you had the chance to build a healthcare system from the ground up, start all over, what would you do? In 1993, Cambodia had to answer that question. As one historian wrote, Cambodia is a victim of its location. Sandwiched between Thailand and Vietnam, it inevitably gets dragged into any troubles that affect the region. In 1863, the French made Cambodia a protectorate. In 1954, it gained its independence peacefully. During the Vietnam War, the North Vietnamese began to build bases inside the Cambodian border. The country was powerless to stop them. Then President Richard Nixon and then Secretary of State Henry Kissinger approved an illegal bombing campaign in 1969. The United States and South Vietnam subsequently invaded Cambodia in 1969, withdrawing in 1970. The head of state, Prince Norodom Sihanouk, was overthrown in 1970 and replaced by a delusional general named Lon Nol. Civil war ensued. The American air attacks became saturation bombings of a large part of the country and continued until 1973. The Civil War, in the end, was won by a shadowy Maoist-Stalinist faction known colloquially as the Khmer Rouge, referred to throughout Cambodia as the KR. They were led by an enigmatic figure who called himself Pol Pot. Phnom Penh, the capital, after fierce fighting and many civilian casualties, fell to the KR on April 17, 1975. Most Westerners fled, leaving the Cambodians to their fate. The KR emptied the cities, forcing the inhabitants to march long distances to work camps where many of them died. The first people who were forced out of Phnom Penh were hospital patients, even if they could not walk. None of them survived. Dr. Hang S. Nor, the Cambodian physician, actor, and chronicler of this tragedy, was interrupted by KR soldiers when he was performing surgery and was forced out of the operating theater and had to leave his patient to die. Bombing and war had already destroyed many hospitals and clinics. The KR destroyed most of the rest of them because Pol Pot believed only in traditional medicine. Physicians and nurses were murdered, victims of Pol Pot's plan to create an agrarian peasant paradise devoid of anyone who was educated or intellectual. As one KR cadre leader announced, "We don't need doctors anymore. If someone needs to have their intestines removed, I will do it. It's easy. There is no need to learn how to do it by going to school." The KR madness went on for 4 long years, during which between 1.5 and 3 million people died. This was out of a population of 7 million. Some groups were targeted: intellectuals, teachers, physicians, nurses, and Buddhist monks. They were systematically annihilated. Most people, however, died of starvation, exhaustion, and untreated illness. However, if you were thought to be disloyal to the KR, and this included children, you were rounded up, tortured, and murdered in special camps or prisons. This memorial pagoda outside of Phnom Penh looks lovely until you get close to it and realize that it is full of the skulls of those who were killed. As Henry Kam, a journalist who described Cambodia's suffering, wrote in 1998, the Khmer Rouge established a nadir so low that any change meant an improvement. That improvement, such as it was, came in 1978 when the Vietnamese invaded Cambodia, drove the KR to a few pockets along the Thai border. The rest of the country, at least, was finally free of them. But by then, there just wasn't much left. Philippe Longfi, a French physician and a hero of mine, arrived around 1980 to care for survivors, and what he found horrified him. Terrified, starving, traumatized children, and families who had simply been through too much. No one knows how many physicians and nurses were in Cambodia when the KR took over. At the time of the Vietnamese victory, the estimate is that there were 25 to 75 physicians left alive in the entire country. No living nurses were found. Many of the healthcare professionals who did survive fled the country as soon as they could. There were about a dozen hospitals still standing, most of which had been abandoned for years, and they had no supplies. The Vietnamese occupied Cambodia for 10 years, and they did try to address the situation. They repaired and built clinics, and they reopened and hospitals, and they reopened the medical and nursing schools. Unfortunately, the dearth of clinicians led them, as a Cambodian physician friend of mine says, to shorten the curriculum. In other words, they were churning out people as medical assistants who had less training than many emergency medical technicians. More than a few of these people declared themselves to be physicians, opened up clinics, and some, unfortunately, are still in practice. The Vietnamese did tighten up medical and nursing curricula before they left Cambodia in 1989. The United Nations then took over and ran the country until 1993, when a former KR officer, Hun Sen, took power, which he still holds. Cambodia is a desperately poor country, and its health statistics reflect that. These numbers are pretty grim, but I can tell you that they're a heck of a lot better than they were 20 years ago, especially life expectancy and child mortality. They've done a good job with HIV, but tuberculosis remains a huge problem. Appropriate care of children with pneumonia and diarrhea is nowhere near where it should be, and per capita spending is a paltry $400, and 2/3 of that is out-of-pocket spending by patients. If you can contrast that with the over $6,000 per capita that is true in the United States, you can get a good sense of the picture. The greatest challenge for the Cambodians has been to rebuild a healthcare workforce that ceased to exist. It's been a long, slow effort. It has about 1.6 physicians per 10,000 population and about 8.5 nurses. That's low even for a region that includes other poor countries such as Myanmar and Laos. Public hospitals come in three kinds: healthcare centers, which are rural, provincial hospitals, and referral or national hospitals. They range in quality. Many of the rural health centers that I have seen are pretty questionable. Conditions in some provincial and referral hospitals are pretty dicey as well. This is the women's ward in one such hospital that I visited, and I was later lamenting to a Cambodian colleague about the lack of bed linens here, and her response, her astonished response was, "They have beds?" Conditions are better at some tertiary hospitals. This is the Soviet Khmer Friendship Hospital in Phnom Penh. However, it is being semi-privatized. It's called public administration enterprise. It's a very complicated transition. And the experience that other hospitals have demonstrated with being semi-privatized is that it doesn't do anything positive for low-income patients. There are some outstanding public facilities, one of which is the government HIV clinic in Phnom Penh, where patients are evaluated and entered into treatment by trained staff, and where, thanks to international generosity, there are sufficient pharmacy supplies. The center also offers support groups and education, both for patients and for the public. There is a burgeoning for-profit sector, including Thai-owned hospitals. This one is in Siem Reap. Can you see the little credit card icons on the bottom of the sign? The hospital is clean, well-staffed, and has state-of-the-art technology, but frankly, its prices would choke a horse, and it had very few patients when I was there. I could not help but worry about its volume to mortality ratio. Generally, if someone who has means develops a health problem, he or she is likely to go to either Bangkok or Ho Chi Minh City for treatment. There are also for-profit clinics everywhere. Some of them are excellent, some of them are good, many of them are just terrible, and there is little regulation or oversight. The saving grace is the non-governmental organizations, or NGOs. Henry Kim also wrote in 1998 that few countries are host to so complete an array of the world's organizations of benevolence as Cambodia, and they attend helpfully to a wide range of needs. that this only scratches the surface is not their fault. Actually, he did write that 13 years ago, and today they're scratching the surface very well. The Sihanouk Center of Hope in Phnom Penh, an excellent hospital founded by a former Newsweek journalist, is training Cambodian physicians and nurses, as well as offering education to clinicians from around the world in the provision of care in low-resource situations. The Angkor Hospital for Children in Siem Reap, and in the interest of ethics and transparency, I do wish you to know that I am a donor to this hospital and provide volunteer editorial services to them. This hospital offers superb evidence-based medical care, including an exemplary cardiac surgery program, and is devoted to training Cambodian healthcare professionals. Every nurse, pretty much, in Cambodia has spent time training at the Angkor Hospital for Children. The Mopatsio Patient Information Center, which is a peer education and support network for diabetics and those at risk of diabetes, which is run by Maurits van Pelt, a Dutch professional of extraordinary talent, skill, and commitment, provides medication, education, and peer support to the poorest of the poor from Cambodian slums. You would be surprised that diabetes would be a huge problem in Cambodia, where so many people are thin and tiny. And the reasons for it are ancient and genetic and clinical and nutritional, but diabetes is a huge problem in the country. If the current trend lines hold, 10% of the population will be diabetic in the next couple of years. Another challenge is landmines. Between 1969 and 1989, 9 million mines were laid in Cambodia. 1 in 250 Cambodians is an amputee as a result, and they are still stepping on them today. Meet Aki Ra, who at the age of 10 was forced to join the KR and then was put to work laying mines around his village and those of others. When he grew up, after surviving all of the violence, he decided he would start removing the mines that he had laid. He started doing it by putting a stick in the ground and looking around for them. Fortunately, someone from the UN came along and said, you know, that's not really the best technique. Perhaps we could train you? Out of that came the Cambodian Landmine Museum and his Cambodian self-help demining program, where he trains villagers in mine removal techniques so that they can clear out the dangers from their own neighborhoods. You all want to empower patients? This guy is empowering people to remove landmines. So what are the current issues affecting quality of care and patient safety in Cambodia? There are a million, I'll only mention a few. First, corruption is a problem throughout the society and has been really since the early days of the French. In one very unhappy poll, Cambodia managed to rank 154th out of 178 countries in terms of the level of corruption. Healthcare is not exempt. I have heard stories of families being forced to pay for donated blood, bribes being extracted from patients for an injection, and special treatment in hospitals, but only if you pay extra. This is not universal, but it is a continuing challenge. It is also unclear what the privatization of some of the major hospitals is going to produce. The good news is their administrations are able to have much more flexibility in budgeting and staffing and in paying the people who work there. The bad news is that user fees have been introduced that are simply unaffordable for many people. The NGOs, some of them have created what are called health equity funds, which pay the costs and fees for some of the poor, but they do not begin to cover the need. And as more public hospitals are privatized, including apparently there are plans to privatize the National Women's Hospital and the National Pediatric Hospital, which I find a very unsettling prospect, I think access for the poor is likely to be severely compromised. Although it's getting better, lack of personnel and underfunding remain major issues, and many of the professionals who have been trained are reluctant to work in rural areas, hardly a situation unique to Cambodia. Resource allocation between rural and urban settings, it remains highly inequitable. 80% of the population is rural, but most government funds are spent in urban areas. And most Cambodians mix and match between traditional and Western medicines, which raises a number of clinical problems: delayed care, drug interactions with unknown substances, medications and herbal remedies canceling each other out. And this is not necessarily the result of ignorance. My best friend in Cambodia, who is a college-educated executive, developed a health problem and asked me about it, and I knew immediately what it was. In the interest of protecting him, I won't say, but it was something that you could fix with an outpatient procedure in any competent clinic in about an hour. He insisted on going to a traditional healer first. Fortunately, he ended up getting appropriate treatment, but it was a real nail-biter for me for a few days there. Also, Cambodia is far too dependent on the non-governmental organizations. Many are doing a stellar job, but the goal should be to train and empower Cambodians. For example, NGOs have been critically important in helping Cambodia control the spread of HIV, but does a little country really need 120 NGOs working on that one condition? I have a Western friend who's been training Cambodian healthcare professionals over there for a number of years. He says the happiest day of his life will be when he can turn the keys over to a properly trained, skilled Cambodian workforce. As George Orwell wrote of his experience in the Spanish Civil War, "Good luck to them all. I hope they win their war and drive all the foreigners out of Spain, Germans and Russians and Italians alike. When you have had a glimpse of such a disaster as this, and however it ends, the Spanish War will turn out to have been an appalling disaster. The result is not necessarily disillusionment and cynicism." Curiously enough, the whole experience has left me with not less, but more belief in the decency of human beings. I feel exactly the same way about Cambodia, but until these issues are resolved, the poor pay the price, bankrupting themselves, borrowing money from moneylenders to pay for care, being forced to sell land that has been in their families for centuries, dying of easily curable disease. Jan Egeland, the great Norwegian diplomat who served as UN Undersecretary for Humanitarian Affairs, once said, "The one human right that the poor and vulnerable should have is to be protected from incompetence." That is not necessarily true in this instance. So, what can we learn from Cambodia's experience? First, and this does reflect the views of all of my colleagues, the human resource is the most critical. Skilled clinicians can work under very difficult circumstances. Just ask our colleagues from Afghanistan. Ask the physicians of Médecins Sans Frontières, who are known as Doctors Without Borders in the United States. Ask the Israelis who had field hospitals set up in Haiti hours after the calamitous earthquake. But if the clinicians aren't there, it doesn't matter how nice your buildings are. Second, non-clinical causes of disease and injury often should be the priority. Dr. Gawande yesterday spoke of our overdependence on pharmaceuticals. Well, my department chairman at Boston University, George Annis, likes to say, every motor vehicle death is a public health failure. I could certainly say the same about diarrhea in Cambodia. It's not bad health habits, it's unsafe water. It is not a clinical failure, but a social one. Third, and this might be the most important lesson that I have learned over the past 3 years, if you want to accomplish your goals, you have to do what works, not what the textbooks say. Someday Cambodians will have safe water supplies, but in the meantime, they are being taught to have a hand washing station, a clean, sanitized basket, a clean towel, a bar of soap, and no contact with animals or feces after washing. The diabetes patients in Mopotio's program cannot afford blood monitors, so they use urine strips, and if a strip shows a result that might be problematic, a peer educator who is responsible for a group of people brings a blood monitor to check it out. Dr. Lonfils, frustrated by anemia in young Cambodian women who eat an iron-poor diet, advocates that iron supplements be added to fish sauce, because everybody in Cambodia eats fish sauce. Yes, for the nutritionists in the room, yes, it's very salty, yes, it's not good for you. But if that's what everybody eats, at least put iron in it. Mapotio also arranged for their very poor participants to get scales to monitor weight. And they first thought about getting these really fancy digital scales, but they broke too easily. So what they came up with was very simple scales that work just fine, and most important, can be mended very easily by program participants. You have to face reality. Many countries represented in this room and at this conference have done a wonderful job, a fabulous job, of reducing central line infections. But you have to realize that most rural Cambodian health workers don't know what a central line is and would have great trouble obtaining one even if they did. Also, everybody wants to talk about egalitarian healthcare systems. I've been at this a long time. Tears are inevitable. Billionaires are going to acquire what they want. If Steve Jobs of Apple Corporation wants to buy himself a liver, he's going to buy himself a liver. Let them. I've stopped worrying about ceilings. Let us focus on floors. Let us commit ourselves to establishing a level of care below which no one is allowed to fall. And in an increasingly diverse world, we have to take cultural practices seriously. It is often necessary to acknowledge the use of traditional approaches, whether you like them or not, because in many cases they are extremely emotionally important to patients. And as I mentioned in my remarks yesterday, mental health issues are largely overlooked in Cambodia as in elsewhere, even in crisis situations. And mental health problems, especially those that result from trauma, can linger for a long time. As I said yesterday, many Cambodians who survived still suffer from PTSD. Funders also have to address need, not what they feel like addressing. The global initiative is pouring money into HIV efforts in Cambodia, a country that's doing okay on that score, and into malaria abatement when malaria isn't all that much of an issue. The funders would do better to do something about unsafe water, diarrhea, diabetes, malnutrition, and tuberculosis. But there's a reason why there are 120 NGOs working on HIV in Cambodia, and that's because that's where the money is. The Society of Friends, the Quakers, have had as part of their mission statement for 50 years the phrase, "Speak truth to power." We all have to speak truth to the funders so that we can get priorities straight. Lastly, the rebuilding of the Cambodian healthcare system has taken place with almost no input from regular Cambodians. It seems to me that the people who are using the system and paying for a great deal of it might be allowed a say in what it looks like. Yes, the Cambodians have had a very difficult time. And yet, despite all, look at what they have accomplished. A 61% improvement in the quality of drinking water, road improvements that are making it easier for rural people to get to health care facilities. The government is establishing guest houses for high-risk rural pregnant women so that they will have access to cesarean sections because cesareans are generally not available in rural areas. More and more Cambodian physicians, nurses, and other healthcare professionals are being trained. Self-management and peer education for diabetics and those at risk of the disease are in place in several provinces. Cambodia has the lowest rate of new HIV infections in the region. Their mother-to-fetus transmission rate is nearly zero. 90% of those who are diagnosed receive antiretroviral treatment. Mortality in children under 5 has dropped from 1 in 5 to 1 in 15. Life expectancy is up considerably. Cambodians use tobacco less than in neighboring countries, and almost no Cambodian women use tobacco. And the rate of immunization for basic childhood disease is above 90%, which is higher than the rate in the United States of America. A brilliant photographer friend of mine in Australia was asked to document one of Prince Philip's charities, which brings at-risk Aboriginal young people from north central Australia to the southern coast for a sort of outward bound experience, part recreation, part learning discipline. One young lady, seeing the ocean for the first time, jumped into it and came out dressed in seaweed like a bride, glowing with the joy she felt at finding something new and wonderful. I'm not saying the Cambodians have done everything right. A lot of it has gone wrong, but they're trying. Many of them are trying very, very hard to find something new and wonderful in healthcare. And if these gentle people who have come back from hell and who have so little can go from this to this in a generation, then those of us in this room, most of whom have so much, can do no less. Thank you very much. I'm afraid I have, thank you very much. You were most kind. I accept your kindness on behalf of a nation of very courageous people. I have no idea if we have time for any questions or discussion, or should I just get off the stage? I'm afraid I can't see anything. Go? Go, okay. My thanks to all of you. I will be around for the rest of the conference. Please stop me to chat.